So for the first session, I invite Professor N. Rajendran and Professor Muthu Selvan to kindly take the dais. Thank you, sir.
Very good morning to one and all. It's a great opportunity for me. Thanks to Professor Shanmugam and the organizing team for giving me this great opportunity to share with my mentor, teacher and philosopher, Professor Sir. And without much ado, I request Dr. Priyamalini to present the first topic. It's a focused set of sessions. GIP in diabetes, what clinician should know. Welcome, madam.
Good morning to one and all, to all the delegates of DAISICON. I thank the organizing committee and the scientific committee, Rajendran sir and Shanmugam sir, Anand Moses sir, for giving me this opportunity. Without much delay, we'll go to the first talk of this DAISICON, the GIP, what the clinician should know. So we all know this is a basic incretin, and this is my blueprint, how my talk goes further. So GIP is nothing but old wine in a new bottle. So this is one of the incretin hormones that was discovered at early. This was the first incretin to be discovered, followed by the GLP-1. So we know what are incretins. Incretins are gut hormones that increases the insulin secretion when given orally than when given in IV thing. So in healthy individuals, this accounts to almost 50 to 70% of the post-meal insulin secretion, and in type 2, this function is impaired. So this molecule, as say, is a 42 amino acid polypeptide or hormone. It's secreted from the K cells of the proximal small intestines. The levels are detected throughout the day except in the fasting stage. It's understood. So whenever you have your meal, you have a increased GIP secretion. The half-life of endogenous GIP is very, very less. Within 5 to 7 minutes, it's degraded by the DPP4 enzyme. And this insulin-stimulating effect of GIP is actually impaired in type 2 diabetes in the post-meal session. So discoveries, as we all told you, this, though it was the first incretin to be discovered in 1960, it didn't gain its importance because it was discovered as a gastric polypeptide. Gastric inhibitory polypeptide, where it suppressed the gastric acid secretion. Later on, the glucose stimulating effect was found, and it was found to be a stronger incretin when compared to the GLP. And it's actually a 42 amino acid, and it's a precursor, 153 amino acid, whereas GIP was discovered late to GIP, but its effect was well studied in advance, and that is, though it is a second incretin to be discovered, its effects are well established. Now, coming to the molecular physiology of GIP. So, both these receptors, both these incretin gut hormones, they act through the G-protein coupled receptors, which are present in the beta cells as well as other cells, organs like kidney, bone and cardiovascular system, brain and so on. So, the most important thing is the physiological action of GIP depends upon the tissue-specific distribution. That is very, very important. So you can see that the GIPR is expressed mainly in the pancreas, brain and fat, whereas GLP expression is present in the pancreas, brain and gut. So both of them act through triggering the G-protein coupled receptors or GPCR receptors, which we commonly say. There is a difference in the insulotropic strength or effects of both these hormones, and that depends upon the distribution and how it is signaled. So how it produces an intracellular pathway. Though it carries a common pathway. It activates adenyl cyclase, then it activates the cyclic AMP, then the protein kinase C, and then enhances insulin secretion. But still, they engage different cascades of action, which we will see later. And GLP acts through activating two G proteins, that is gas protein and GAQ protein, whereas GIP acts only through activation of gas protein. So there is definitely a divergence in the intracellular signaling, and that what explains the mystery of action as for in the targeted therapies. So, and the variation, you definitely have an inter-individual variation in both healthy individuals as well as type 2 diabetic individuals. So this is a very interesting slide. You can see where all these receptors are distributed. So where all you have GIP stimulation, you get action in all these organs. So you get a pancreatic effect. It is distributed in the beta cells as well as the alpha cells. It has a liver distribution, adipose tissue distribution, especially the subcutaneous tissue and brown fat, as well as a distribution is present in the brain, the gut, the adrenal glands, the bones, and even the eyes. So where all the receptors are distributed, you get an effect of this hormone in a physiological action. So what is this GIP? What does the role it has in a physiological action as well as in health? So this is very well understood. In a normal person who has a normal, who takes in a lot of food, this hormone is a gut hormone stimulated by the intake of either fat or glucose. It is a glucose, it produces a glucose-dependent insulin secretion or insulinotropic effects. So the action towards fat is more than that of the glucose. So when you start eating glucose stimulates, the GIP is secreted from the gut. It produces more than 2/3 of the insulinotropic insulin secretion from the beta cells and also causes intestinal glucose absorption. So this is an anabolic hormone. So once you have insulin, you have an anabolic effect. So there's going to be glucose uptake as well as storage in the adipose tissues, skeletal muscles and hepatocytes. So this is a normal action of GIP in health. But what happens in pathophysiology? When the patient becomes obese, he's going to take a lot of nutrients. There's overexpression of GIP. This overexpression of GIP is once again going to increase a lot of insulin secretion as well as nutrient absorption. So you get adipokines secreted and you get lipogenesis and leading to obesity, insulin resistance and even type 2. So this is what happens in a normal effect. So coming to the pancreatic, extrapancreatic and central actions of GIP, this is very important because it's based on this where a lot of targeted therapies have been developed. So the direct effect is insulinotropic effect where you have a glucose-dependent insulin secretion. But type 2, this is impaired. Though GIP is secreted in a balanced form, there's a lot of insulin resistance happening. And beta cell survival, there is an anti-apoptotic effect of GIP and proliferative benefits are well studied in a lot of preclinical studies. The beta cells are preserved. There is a differential action on glucagon secretion in health and type 2 diabetes. What does it mean? Glucagon secretion is also glucose dependent. So when the glucose levels are higher, the glucagon is not secreted. When the glucose levels are low in hypoglycemia, the glucagon is secreted. So this is in healthy individuals. But type 2, this differential variation is impaired. So you have a resistant action. So in the incretin hormones, pathophysiology in type 2 is little different. So here you can see in type 2 diabetes, the incretin effect decreases despite a normal GIP secretion. So this is basically due to a GIP resistance. And chronic hyperglycemia per se, we know is going to downregulate the insulin receptor, so you'll not have much of insulin action. So this GIP resistance is very high in the case of type 2 diabetes. But it retains its residual function of secretion of glucagon. So even when you have a hyperglycemia, the glucagon secretion is a little bit increased. So this resistance is overcome when you break down the glucotoxicity in type 2 diabetes. So when you break down this glucotoxicity, the endogenous function of GIP is recovered and the GIP starts working even more better. Now, the effects on adipose tissue, liver and muscles. In adipose tissue, it enhances insulin sensitivity, lipogenesis and triglyceride storage on adipocyte. Mainly, it increases the adipose tissue blood flow and has a better lipid utilization. In the liver, it has a paradoxical effect. In healthy individuals, it tries to reduce the hepatic output and glucagon-stimulated glycogenolysis. Indirect effect, it enhances the TGL clearance and energy stored in adipose tissues. But in obese patients, there is a hypersecretion of GIP taking place, so it may promote fatty liver or insulin resistance. In the skeletal muscles, it promotes a glucose uptake and utilization. As an enterogastin, we all know it inhibits the gastric secretion via somatostatin, and along with other hormones like GLP-1, peptide, it regulates the gastric acid secretion and motility. In the bone, it suppresses the osteoclastic activity and resorption markers, so thus it improves the bone marrow density and integrity. The cardiovascular effects, there it regulates the heart rate, vasodilatation and blood flow. It also lowers, it has an anti-inflammatory property, so atherosclerotic, anti-atherosclerotic and anti-inflammatory property, and it modulates the metabolism and function of the cardiomyocytes and cardiac protection for the ischemic injuries. Coming to the central actions of GIP, it has a wide area of distribution of its receptors, not only in the hippocampus, but also in the substantia nigra, nucleus of tractus solitarius. These are the centers which actually promotes the satiety effect or the aversive effect of this particular molecule. But in general, it supports cognition, coordination and energy balance, and this chronic GIP signaling, because of the presence of this receptors, it lowers the food intake. So the satiety is promoted and body weight is also lowered, and this action is brought about by the GABAergic pathway. And the main power effect is primarily a nutrient uptake and storage, as we all discussed. Now, coming to the next part is that with this efficient molecule, a lot of targeted therapies have emerged addressing for the type 2 diabetes management as well as obesity. So initially, the studies have proven that this molecule is obesogenic. But recent studies have proven in agonism, GIP agonism or chronic agonism with this chemotherapeutic analogs can have a therapeutic benefit in obesity. And the concept of antagonism have also arisen because studies have shown in a GPR knockout mice, when they were given a diet rich in fat and they failed to develop obesity. So they were protected from developing diet-induced and genetic-induced obesity. So this was a concept which was promoted in developing GPR agonist. And recently, we have the dual agonist in market, both the GLP-1 receptor agonist and the GIP receptor agonist. So this dual agonist activation, co-administration, once again is beneficial in the treatment of type 2 diabetes and obesity. So this is n number of clinical studies which proved the efficacy of GAPR. And the tirzepatide, the study of tirzepatide, when you look into this, the clinical studies have started way back in 2018, where it has been studied in various aspects in the control of type 2 diabetes, the control of obesity, then it is tolerability for long-acting GIPs and so on. So the clinical studies and as well as the I'm not going to go through each and every one. This proves the efficacy of the molecule, and n number of background work has been done to prove the molecule is efficacious. Now, this is the most important thing of developing the various targeted therapies of GIP. So the GIP receptor signaling pathway, it does have a mysterious action profile. So can I have a pointer, please? So just look into this. This is the, you can just visualize the GAPR receptors that is found in any of the, taken to the beta cells. So when the ligand binds, as an agonist binds to this receptor, there is a lot of activation taking place. And GAPR acts to, as I already told you, to the GAP proteins. So that activates the adenyl cyclase and the cyclic AMP and the protein kinase C, and that protein kinase C enhances the insulin secretion and through its way of action. But you can always say there's, in addition to the recruitment of this GAP proteins, there is also recruitment of beta-arrestin. So what does this beta-arrestin actually do is that this beta-arrestin tries to internalize the receptor. It tries to engulf the internal part of the the GIP receptor. It encloses them in the endosomes, and this decides whether the receptor has to go for endosomal signaling or recycling or degradation. So this internalization and recycling is brought about by this beta-arrestin. So the entire pathway is dependent upon this beta-arrestin. So why this is important? Why this receptor signaling is important? That this explains the agonistic and antagonistic action of GIP. So as you can see this, when you have an agonistic action, this entire cascade is taking place. But when you have an antagonism occurring, it blocks the beta-arrestin also. So the recycling of the receptors is prevented. So less number of receptors available in the surface for action. So that brings about the antagonistic effect. And when you give a dual agonist, there is going to be a functional antagonism because of the recurrent internalization and some amount, and the GLP, but the GLP receptors are not blocked. When you're going to give a dual agonist of GIP agonist with GLP-1 receptor agonist, the GIP action are blocked. That is promoted to the GAP proteins are blocked, but that which is promoted by GAQ proteins, that brings about the GLP-1 receptor action, that is not blocked. So the GIP expression is blocked, but the GLP-1 actions are enhanced. That is how the dual receptor act. So you would definitely have a good amount of diabetes control as well as weight reduction. Now, what are the targeted therapies of present and future? We all understand the pure GIP agonists are yet to be in market. It's still under research. Whereas the dual agonist, the GIP receptor agonist and GLP-1 receptor agonist tirzepatide already into market and doing well. This is mainly used in management of type 2 diabetes as well as weight control, obesity. The receptor blockers are antagonists. We have one molecule under research, the GIP33N92 is a truncated inactive peptide which is going to act as an antagonist, and the other molecule is a maritide. This is a combination of two GLP-1 receptor agonists with one single GIP antagonist. This is almost in the phase 3 trials. So you have n number of targeted therapies for this particular receptor, so which is going to be beneficial in future. Now, the molecule has gained importance. The dual agonist, which is into market, has gained importance because of its action on obesity. So how does it act? So incretin action of obesity is well known. Mainly, it reduces the food intake, it increases satiety, it increases the thermogenesis also. It tries to convert the subcutaneous fat into brown fat and reduce food cravings and delays the gastric emptying. This is how it brings about its effect in obesity. And you have potential targeted therapies, the dual agonist, then you have chronic GIP agonism, you have antagonist, as well as individual therapies of GLP-1 receptor and GIP. So all these are targeted therapies which are going to target against the GIPR receptors in the adipose tissue as well as the pancreas. So this is how the effect is brought about when you give GAPR analog. The effect is produced in the gastrin, CNS and the pancreas, and the GIP either as an antagonist or a chronic agonism is going to produce the same effect, where you have adipocyte glucose uptake is reduced in fat cell, glucose uptake in intestine is reduced, and pancreatic effect and lipogenesis and adiponectin are reduced. So the central action is improves the satiety and decrease the food cravings, and also in the adipose tissue has thermal conversion. So thermogenesis takes place, increased energy expenditure takes place, and there's a conversion of subcutaneous fat to brown fat. So a word about the dual receptors. There are two molecules under study, and one is already into the market. The first one is a 40 amino acid peptide. This is a balanced GIPR and GLP-1 agonism. And tirzepatide, the 39 amino acid, is an acylated product. This has imbalanced agonist and strong GIPR affinity. This imbalanced receptor action is most important for the tirzepatide action. So it has a more of GIP activity. So when it acts as GIP agonist with a higher affinity to GIPR receptors, the GLP is overstimulated. So the actions are brought about by the GLP-1 receptors. So it has a dose proportionate action, and the acylation enables albumin binding, and tirzepatide shows there's a biased GLPR signaling, and it is a superior glucose and weight reduction versus the other molecule. And the scientific evidence, we do have the SURPASS trial 1-5, which has proven the safety of this molecule in glycemic control, in weight reduction, the cardiovascular safety in type 2 diabetic patients. So it has a sustained dose-dependent glycemic control, and efficacy in weight loss and cardiometabolic benefits are well proven through this trial. And to the last, the gist of what the clinician should know. This is a molecule which is lately into the market, but with the latest effect. It's a first and strong incretin. It enhances post-meal insulin secretion. Almost 60 to 80% of post-meal insulin secretion is by GIP. It's rapidly degraded. The endogenous one is degraded by DPP-4, and the effects are blunted in type 2 due to GIP resistance. Metabolic effects, it has a strong effect on metabolism, weight control, cardiovascular benefits, bone remodeling, CNS action, and gut functions. Targeted therapies against type 2 diabetes and obesity are highly beneficial, and tirzepatide, the boon in diabetes management, the dual agonist shows superior A1C reduction and weight reduction proved through the SURPASS trial, and antagonists are awaiting for action. Thank you.
Thank you, Dr. Priya, for an elaborate and extensive deliberations on the topic that the GIP. You have nicely told that the physiology and also pathophysiology, and even you have compared with that the GLP-1. And another things, what is more important for this clinical diabetologist, what is that its impact in the clinical diabetology, that also you have covered, the actions, and also and nowadays that the gliptins are the cornerstones in the things. In that way, how this your GIP is useful. And you have told nicely about that the dual effects, agonist and as well as antagonist actions. And you have nicely at the last you have covered the role of that the GIP agonist currently that you have more in tirzepatide you have elaborately you have told. Of course, what you have deliberated will be useful clinically for the delegates. So by and large, thank you very much for your nice deliberations.
Thank you, Professor Priya ma'am. Having traveled the incretin with the guidance of Professor Priyamalini, now it's time to preserve the beta cells. I request Dr. Pushpa Saravanan to present from bench to clinic aspects of beta cell preservation. Over to ma'am.
So good morning, everyone. once again. And thank you, organizers, the scientific committee, who has given me this opportunity. I'm also there in the committee. That's why I'm laughing. Okay, so, excuse me. So Dr. Priya has given us a very nice perspective about the GIP and GLP also along with her GIP. So now I will talk on the beta cell preservation from bench to clinic. So when this topic was given, I was thinking, what is beta cell preservation? And I remembered in childhood, we used to see one advertisement. And at that time, I didn't understand it. When I saw the ad for the first time, it showed that one woman, they say that Mrs., say any name, Mrs. Mohan, XYZ, she's washing her linen. That was the tagline of that advertisement. And I see one woman, she just comes and sits in a chair and starts reading book. For a very long time, I was not able to understand the advertisement. Afterwards only I understood it was the automatic washing machine. So the woman is our beta cell. So our mothers used to wash clothes with their hands, get exhausted. And now, at that time, the automatic washing machines came into the market. So the beta cell exhaustion, the exhaustion of the mothers stopped. So here we talk today about the beta cell preservation. So technically, the drugs earlier which were used traditionally, they were directly acting on the beta cells and exhausting these cells. So now the newer therapies have started coming up, which are more helpful in giving rest to the beta cell. So what is how is the beta cell mass maintained? So it is a very fine balance between the expansion and the cell loss. So as in other tissues in the body, the apoptosis keeps taking place, and then there is another concept called beta cell dedifferentiation. So whenever there is glucotoxicity, lipotoxicity, these beta cells, they convert into other types of cells within the pancreas. At the same time, there is beta cell mass expansion. This happens in normal people. So there will be replication, non-beta cells will convert into beta cells. That is, redifferentiation also takes place, and then there is hypertrophy. So hypertrophy usually takes place when there is insulin resistance. So this fine balance will keep the blood sugar under control. At any point of time, if this balance is lost, we will have pre-diabetes, which will march into diabetes. This is another important one. Why we are bothered is because South Asians have a different kind of phenotype. They are thin fat Indians, and we all know that they have more atherogenic profile, more inflammatory profile, and though they may appear non-obese, the abdominal fat, the visceral fat does all the graces to them, and they develop all the complications at a much earlier stage. So they develop diabetes and the CV risk and cardiovascular disease at an earlier stage. Because of this Asian profile, there is increasing prevalence of diabetes in younger and younger age group. The cost of treating diabetes also comes higher because of the indirect cost of the complications. The risks are more, the risk of complications is more, and to achieve the glycemic control, it becomes difficult because of the basic nature of the person, the inertia from the physicians, and the cost of therapy. Now we need to give individualized patient care for glycemic control, and there are multiple choices, and more are coming into the market. And already Dr. Priya had talked of certain molecules which are in the pipeline in phase 3 studies, and there are many more. And how to utilize these drugs in the management of type 2 diabetes is what we will see in the next few minutes. And why we want to do this? Because already at the time of diagnosis of diabetes, more than 80% of beta cell has been lost. So we need to initiate the treatment very early so that the disease doesn't progress, and these interventions should help in prolonging the beta cell function. So we are not going to destroy whatever is already there. Now what do we need to know? When to arrest the rapid progression of diabetes? Can we rescue these failing beta cells in all the patients? What will be the treatment strategy? Should we be aggressive or conventional? Should we use combination therapy? And how do we achieve the treatment strategy safely? So now we have moved ahead of the monotherapy. So earlier we were like one drug and then we go to the maximum dose and then come to the next drug. So now it is seen that monotherapy typically fails within 3 to 5 years in most of the patients. Hence all the guidelines, they advise early combination therapy to improve the glycemic control. It will reduce the beta cell stress by lowering the glucotoxicity early on and reduce the insulin demands. And this is particularly important for high-risk population, the young onset diabetes like our Asians. So what are the key considerations in beta cell preservation? There should be long-term durability, which requires moving beyond HbA1c reduction. So that is not the only thing we need. And we have to take into consideration our phenotype, lifestyle is the mainstay, and along with pharmacological interventions. And we have to overcome the clinical inertia and a shift from glucose-centric to beta cell-centric management. Even the landmark trial, UKPDS, it showed that early therapy reduces long-term microvascular complications. ACCORD showed good results, but then there were hypo risk was always there. Then we have the other newer drug trials, EMPERAC, CANVAS, DECLARE, and all SURPASS. All these studies have shown that if we are able to give a good glycemic control, and these drugs, apart from giving glycemic control, they are also able to give CV protection and renal protection. So important is the clinical inertia. So now this clinical inertia is not just limited to the clinician, it's even on the part of the patient and their caregivers. So there is definitely a not so intensive treatment at the time of poor HbA1c control. So at the time when the HbA1c is very high, we have to be very proactive and use multiple agents. See to it that the patient comes for regular follow-up so that they don't go in for hypo. And the reason could be the time, the resource, and the safety concern, because more aggressive treatment has more chances of hypoglycemia there. Then we need to educate the patient, make them understand how to take the decision. Decision support tools are needed. Then we have to prioritize the beta cell preservation rather than just giving drugs to reduce blood glucose. And early combination therapy helps to bypass inertia by avoiding stepwise delays, and we need multidisciplinary care models to reduce the inertia. We need the help of an educator, a dietitian, along with the primary care physician. So we all know lifestyle interventions, they do help in beta cell preservation. Calorie restriction will improve the insulin sensitivity, reduce the glucotoxic stress. Then exercise will also improve the peripheral glucose uptake. Look Ahead trial had shown durable improvement in HbA1c with lifestyle. Weight loss will delay the progression from prediabetes to diabetes. And again, lifestyle interventions have shown remission in some patients. Now, the various classes of drug, we start right from insulin sensitizers. Metformin, we all know, it doesn't touch the beta cells, but it has peripheral actions because of which we get better results. Then we have thiazolidinediones. They reduce the lipotoxicity. They preserve the beta cell mass in animal models, and it has shown to improve durability in long-term studies and added benefit in NASH and MASLD. But the only problem with the drug is the weight gain, edema, and fracture risk. So we have to remember the adverse effects, the problems which the patient can face, and based on that we can time the medications. So we can withdraw it within a few months. So these are the things we have to keep in mind. So which drug to withdraw when the blood sugars are starting getting controlled, we have to keep in mind, because pioglitazone has more fracture risk in postmenopausal women. DPP-4 inhibitors, they are weight neutral, but they increase endogenous GLP and GIP levels. They also support glucose-dependent insulin release. They are safe across elderly and CKD patients, improve beta cell function markers, and CV outcome trials have shown neutral safety profile. Then we have the GLP-1 receptor agonists, and already Dr. Priya had talked a little about it. So these drugs also are glucose dependent. They cause glucose dependent insulin secretion, reduce glucotoxicity and lipotoxicity, and they support weight loss, thereby reducing insulin resistance and beta cell strain. And they are a strong candidate for long-term preservation because they also have CV risk reduction. SGLT2 inhibitors, we all know about this drug. now extensively used class of drug which reduces glucotoxicity by lowering the plasma load, improves the HOMA-B, may reduce oxidative stress and apoptosis and pancreatic islet, and has CV and renal benefits independent of glucose lowering. So will we be able to reduce the blood glucose or not? It may not show a very aggressive reduction in HbA1c, but then the CV protection and renal protection puts it far ahead of other medications. Now insulin, though it causes hypoglycemia, this is one drug because we are going to give it exogenously, the endogenous insulin will be safe. So the beta cells will be protected. So this is the most underused drug in management of type 2 diabetes, and it is very important to use early intensive insulin therapy in type 2 patients where the HbA1c is more than 9. And this drug, there is not physician inertia, a very strong patient and caregiver inertia. The patient may also be willing, but the spouse will not agree to start the patient on insulin. So we have to do a lot of patient education when it comes to initiate insulin. And it requires education and least accepted by patients and physicians alike. Now another form of treatment is bariatric surgery, which is effective for type 2 diabetes and obesity. Bariatric surgery has shown remission, improves insulin sensitivity and beta cell mass, modulates the gut hormones. Then we talk a few words about beta cell preservation in type 1. So certain drugs like teplizumab is available, which gives immunomodulation. Then we have islet cell transplant, stem therapy which is coming up, gene therapy. So these are all in the very early nascent research stages, especially the stem cell therapy and gene therapy. But these are the future directions. What is the logo or motto of our conference? So these are the future directions for treatment of type 1 diabetes. And what is new, what is there in the pipeline? There are some drugs which are newer like imiglin, which improves the mitochondrial dysfunction, which is again one very important pathogenic mechanism of all the complications related to diabetes, be it microvascular or macrovascular. Then we have GLP-1 and GIP receptor agonists like tirzepatide. And in phase 3 clinical trial is the bispecific molecule maritide, which Dr. Priya already talked about. And then there are glucokinase activator like dorazelaitin, and this drug is also in phase 3 clinical trials. So, and I have just named a few. There are many more which is beyond the scope. So finally, what are the practical implications for primary care physicians? We need to screen early, initiate therapy early, discuss lifestyle modifications as equal to pharmacology. So, sir used to always teach 4 legs of the table. So, patient education is important, lifestyle modification, drugs and insulin. So, all these things should be taken care of. Choose the therapies with evidence of beta cell preservation and safety, monitor patients for treatment response, and escalate without delay, and at the same time de-escalate whenever you suspect that the patient may go in for hypoglycemia. Focus on preventing complications, not just achieving the HbA1c targets. So what are the future directions? Novel incretin therapies, they have shown enhanced durability. Continuous glucose monitoring supports earlier intervention. AI-driven models may predict beta cell decline trajectories. Pharmacogenomics, they may personalize the therapy for better preservation of beta cells, and research focus is now shifting from glycemic targets to disease modification. So to conclude, I would like to say that beta cell decline is central to diabetes progression, and early intervention is critical to preserve residual function. Combination therapy provides greater glycemic durability. Guidelines, they emphasize acting early and intensifying wisely. Physicians must overcome the clinical inertia for better outcomes, and our goal should be to shift from glucose-centric care to beta cell-centric care and durable management. Thank you, everyone, and thank you, sir.
Thank you, Dr. Pushpa. In fact, he had told how this beta cells decline during the course of the disease, the diabetes, and the ways and means of preventing the beta cell decline and preserving the beta cell mass, which is the aim of the treatment by all. And you have nicely touched upon the pharmacotherapy. Especially given due importance to the insulin and also the problems faced not only by the patients but also by the physicians. You have nicely told that the word physician's inertia, of course, that is always there, and that the physician should overcome the things. And also you told nicely about the future managements, and you touched upon the current artificial intelligence role in this preserving the beta cell. Nice, Pushpa, for your deliberations. Next, I'll be very happy to invite Dr. Prakash, who is a professor of diabetology, Mohan Kumaramangalam Medical College, Salem. He is going to talk really an important and useful talk for that practicing diabetologist. Will this CGM, that is a continuous glucose monitoring, is going to replace A1C? Really, we are all waiting for your deliberations and hope you will give a solution for this. Should we continue to go with the HbA1c, or we have to replace it with the CGM? Dr. Prakash.
Good morning, one and all. At the outset, I thank the chairperson, all my teachers, seniors, colleagues, and my dear friends. Today, the topic that was given to me is like a debate, CGM or HbA1c. So we all know HbA1c is a standardized measure of glycemia, and it is a measure of previous 8 to 12 weeks glycemic control. We have rich evidence linking A1C and complications. Still studies are going on based on HbA1c only. What are the advantages of HbA1c? It can very well be done in non-fasting state, increased stability and fewer fluctuations from the past stressors or illness, and it is an effective tool in assessing glycemic state for management, and now it has been included even in diagnostic criteria 1 decade back, and landmark trials as well as ongoing trials are still using this measure. But what are the limitations? The limitations is the anemia. There is a false elevation in increased lifespan with decreased turnover, particularly in iron deficiency anemia and hemoglobin variants. Similarly, there is false low values when there is a decreased lifespan, hemolysis, post-transfusion and all. And still there is a debate on ethnic and racial difference on HbA1c level. And it does not reflect the day-to-day glycemic excursion. It cannot predict hypoglycemia, and it is not helpful during management whether to increase or decrease the dose. Now we have self-monitoring blood glucose, which is very important to achieve the glycemic goal. Both SMBG and HbA1c measurements are complementary, but self-monitoring glucose itself has certain limitations. It doesn't indicate the rate of change of blood glucose. It cannot detect the nocturnal as well as asymptomatic hypoglycemia, and glycemic variability, which is an important measure that is recently been spoken of. So that cannot be measured with self-monitoring blood glucose. So these are two patients. One is both are having HbA1c 8%, but one of the person has increased glycemic variability that causes more complications. But HbA1c achieved with decreased glycemic variability has a reduction of complications. So SMBG is like taking a photograph, whereas CMBG, the continuous glucose monitoring, is like taking a videograph. It depicts all the variations throughout the day. So the world is changing. Now we are moving towards the time in range. So this is the continuous glucose monitoring. It continuously captures the glucose profile over number of days. It provides the valuable data on the glycemic state beyond produced by HbA1c. So this is a sensor which is owned by, it can be used at any time throughout 24 hours. So we have two different types of CGM. One is real-time CGM and another one is intermittently scanned CGM. Now we have so many CGM devices, Libre, Dexcom and Medtronic and all, and now we have implantable CGM even, which can be kept for even 180 days, and most of them are used for 2 weeks. And now we have devices which do not require any calibration or warm-up time, and most of them are non-adjunct type, that is we need not check with self-monitoring blood glucose, and now CGMS is attached with automatic insulin delivery system, that is with insulin pump. So there are measures of measuring the quality of CGM even. That measure is called MARD, mean absolute relative difference. This is an assessment wherein the value should be between 8 to 14%, so that indicates quality of CGM. And there are certain substances interfering with the CGMS. In certain instruments, Dexcom and Medtronic will have interference with acetaminophen. Alcohol interferes with Medtronic Guardian. Ascorbic acid with Freestyle Libre. Hydroxyurea has a Dexcom interference, and mannitol with Eversense. Tetracycline with Eversense. And what is this time in range? That is an important measure of CGM. The time in range is the blood sugar should be between the range of 70 to 180 milligram around in 24 hours of day, more than 70% of time. And we also measure the time spent below and above range, time below range and time above range. And TAR is used as an endpoint assessment in clinical research as well as glycemic measure. Now we have lots of evidences of involvement of time in range association with microvascular and macrovascular complication. Where all we need to use this CGMS, type 1 diabetes is a definitive indication. Now the ADA states that it has to be used from the diagnosis of diabetes, and CGMS is very helpful in pregnancy diabetes, where we need to have a strict control, and patients who were on multiple dose of insulin injection, particularly in type 2 diabetes, secondary failure, it's very helpful. And it's also helpful in autonomic neuropathy, persons having hypoglycemic unawareness. Similarly, patient with insulin pump therapy requires CGMS, and now CGMS is used even in pre-diabetes state to change the lifestyle. The diet, the pattern of habit can very well be changed with CGM. So these are all studies showing that for each 10% less of time in range, retinopathy progression increased by 64% and microalbuminuria outcome by 40%. So there is even correlation of HbA1c with TAR. For every absolute 10% change in TAR, there was a 0.8% reduction in HbA1c. So there is a good correlation between HbA1c and TAR based on the TAR values. So what are all the advantages of CGMS? It doesn't require finger stick because frequent prick itself is a burden to the person with diabetes, and it measures interstitial glucose every minute, and it can be used to detect short-term patterns of glucose. We can predict hypoglycemia, we can predict the glycemic variability, which is an important measure in causation of complications. It's very helpful in type 1 diabetes. What are the disadvantages or demerits of CGMS? Although it is expensive, it is not now that much expensive, and there is a physiological lag time between the change in glucose level in the blood and the interstitium. It doesn't assess that much of low glucose, and the interstitial glucose has a high variability, and it is not linked to long-term complications. Still, we do not have studies on long-term complications with use of CGM. So this is the international consensus, wherein the blood sugar between 70 to 80 has to be maintained more than 70% in type 1 as well as type 2, and above TAR should not be below some 5%. In higher and older age patient, elderly patient, the time in range has to be maintained less than 50% even, because we need to prevent hypoglycemia in elderly. In pregnancy, it is different, 60 to 140, that should be the target, and it should be achieved in more than 70%. So this is one of my patient wherein CGM helped in management of diabetes. The insulin adjustment can very well be done, and the diet pattern as well can be changed. This is another patient with type 1 diabetes where we had recorded asymptomatic hypoglycemia, particularly nocturnal hypoglycemia. This is another patient, we required almost 150 to 200 units of insulin, wherein it was very well controlled with the use of CGM. With blood glucose monitoring, I found difficult in controlling, but when we used the CGM, it was a very good tool in managing gestational diabetes mellitus even. And this is another person who required both OHA and insulin, and it was very difficult with BGM, but with CGM, with combination of insulin as well as oral drugs, we need to achieve TIR. So these are all various studies on CGM. This is an in-control study wherein CGM use result with impaired awareness of hypoglycemia result in overall increased time in normal range with reduced time in both hyperglycemia and hypoglycemia. This is another study called Diamond trial, wherein it was done in older persons with type 1 and type 2 with multiple dose of insulin, wherein with this study showed improved glycemic control as well as improved HbA1c. This is a concept trial which was done in pregnancy with type 1. This also showed that CGM use was associated with improved neonatal outcomes, which likely attributed to reduced exposure to maternal hyperglycemia. So CGM should be offered to all pregnant women with type 1. This is a recent evidence from ADA, wherein they shown that as of now only concept trial was done for type 1. Now we have evidence for use of CGM in GDM even. This trial has shown that pregnant people with GDM can achieve significant higher percentage of time in range. In this study it was shown that most of the patients were on 90% of time in range. And there was also a 20% difference in the rate of spontaneous vaginal delivery instead of cesarean section. But it is not statistically significant, but although it is very helpful in management of GDM. And this is another study which was published recently in Diabetes Care, wherein it was shown that women with GDM who attained a mean glucose of less than 110 and more than 90% of time in range at 29 weeks of gestation was associated with low risk of suboptimal offspring outcome. So to conclude, HbA1c is still the gold standard for diabetes management. CGM will help in achieving the HbA1c goal. TIR provides a closer view of person glycemic status. Increasing TIR is very beneficial in reducing the micro as well as macrovascular complication. International guidelines have now been updated to include consensus on CGM data. Now we need to move from HbA1c with CGMS instead of blood glucose monitoring. Thank you very much for your patience hearing. Thank you.
Thank you, Dr. Prakash. In fact, yet we have to find a solution. We can go ahead with the HbA1c or go ahead with the CGM. Of course, CGM definitely has gotten a many advantages, as you have told, because it will tell that the hypoglycemia, especially if it occurs during the night. And another thing, keeping that the TIR beyond 70% to 90%, especially in the case of GDM, definitely it nullifies that the complications. And these are all the things. And of course, the one problem with that the CGM is the practical problem. In some devices, normally that shows about the 30 grams less. That is a problem with that CGM. Of course, that has to be taken into account. And another thing, as you already told, it is a little costly, and how far it is going to the patient complement. Only the years to answers, the time is going to answer. However, it is a nice topic for that the audience, and especially who are sitting in the back, that is the newcomers, that will, because you have told some new metrics, TIR, TAB and all these things, that the young doctors will understand and they will be benefit out of your talk. Thank you once again, Prakash. And now these three topics, if you have got any doubt, you can take few minutes to ask. Otherwise, I will conclude the sessions and move on to the next sessions.
Clarification. Of course, the chronic hyperglycemia and persistent stimulation of beta cell with the help of sulfonylurea is causing beta cell apoptosis. So to avoid that, in combination therapy, some of the practitioners are under the impression metformin plus glimepiride also combination therapy. So metformin plus alpha glucosidase inhibitors, metformin plus pioglitazone, metformin plus DPP-4 inhibitor, because before the year 2000 only we had metformin plus sulfonylurea as combination. Now we have metformin plus so many other armamentariums there to avoid beta cell apoptosis, because the persistent stimulation of beta cell with the help of sulfonylurea closes the potassium channel, opens the calcium channel. This persistently increased calcium inside the beta cell causes apoptosis, beta cell degranulation. That we have to highlight.
Sulfonylurea also with metformin and glitazones and yeah, everything. Yes, so point taken, sir. Thank you so much, sir.
Regarding CGM also, sir, CGM, it will definitely help us for 14 days only. Some of our own colleagues, doctor colleagues are continuously wearing CGM. Once after having 14 days, then again they wear. Some of them are wearing for 6 months also. Some of them are under the impression they are fancily wearing and seeing that too now with the cell phone they could see with the, but of course once you assess on your food habit, it need not be wear continuously also. But unfortunately some of the doctor colleagues themselves are wearing continuously.
Yes, sir. Actually, the osteoclastic activity is reduced. So you have a better bone turnover. And the bone mineral density is seen to be improved in a lot of studies. The preclinical studies have already proved it. Other benefits, yes, sir. It has on the, the liver it acts, then the adrenals, it also has a, secretory effect. Yes, sir. And anti-arthrogenic and anti-inflammatory properties are well documented. It's cardioprotective.
But regarding the beta cell preservation, I would like to know whether there is really an entity called as beta cell failure on first exhaustion, then failure. Is there really an entity or not?
Yes, sir, it is there. That beta cell failure is the one in type 1 diabetes where we have to give lifelong insulin. Even in type 2, long-standing type 2 also, there is beta cell failure, because at that point of time, the patients have to be given insulin, they become insulin requiring diabetes. So for good control, we have to give insulin.
If is so, then why should you give DPP-4 in elderly patients? DPP-4 will act only if there is a residual beta cell. Then only it will act. If there is no beta cells at all, how can this DPP-4 act? Because I got patients 90 plus. I am giving DPP-4.
Yes, sir. DPP-4 inhibitor doesn't just increase insulin secretion, it also suppresses glucagon, one action. Then it has central action where it will reduce the appetite. So for all those other actions, we can use DPP-4 inhibitors in type 2 diabetes, elderly or renal failure. We can use, sir, nothing wrong. So for the other effects of DPP-4 inhibitor, we can use it. And yes, if there is beta cell failure to the tune that there is no insulin, you can always check the C-peptide of the patient. So if it is so poor, it is better to give insulin rather than trying continuously giving this drug. Yes, and it may, it will help in improving the synthesis of insulin. Yes, we already discussed that.
Yes, theoretically it is possible. Okay, if there are no questions.
To add, so the glycemic variability also getting nullified, sir. Even though there is no beta cells, it is tried in type 1 diabetes also, or in type 2 diabetes, total beta cell failure, no harm in using. You should not use sulfonylurea only, but you can use the DPP-4 inhibitor, because whenever the blood sugar comes down, it stimulates the alpha cells, prevents the hyperglycemia. Whenever the blood sugar goes high, it supports the beta cells, provided if it is there, it prevents glycemic variability. So we can use.
Okay, now once again I thank the organizers for giving us an opportunity to chair the first and wonderful sessions. So we are concluding and we will be moving on to the next sessions. I will give the mic to my co-chair.
Thank you very much. Very enlightening sessions by all the three speakers. Thank you very much for all the speakers. So thanks organizer for giving me the opportunity to chair along with my teacher, mentor, philosopher. Thank you, sir. Thank you.